load on the health services in the health system overall. And the main aim is how do we keep our needs of the health system and how do we keep the pressure and load on the health system within our health system's capacity, so that we don't overwhelm the health system, and when we overwhelm the system, something called the thrashing effect starts happening, and even when diseases are not as deadly, people start dying, and the mortality starts increasing just because of the fact that they don't get access to healthcare. So the outline of the lecture will be, I will basically talk about it in 4 stages of a crisis management. It's well known within the literature of crisis management or disaster management that there are 4 stages to managing a crisis or a disaster. And these 4 phases are preparedness, response, recovery, and mitigation. The preparedness stage is basically before the crisis happens. So in our case, before the pandemic actually hits. Response is when the crisis actually arises, in our case, when the pandemic actually reaches our shore, and then we have to react to it. The recovery is once we are beyond the response phase, when we are beyond the initial phase and we start returning to a normal, and in many cases, a totally new normal. And then mitigation is forward-looking as to how we start living with the new normal, how we start, in our case, maybe start living with this virus, and share this globe, if you will, with the virus. And the way I'll talk about it is in each stage, I'll sort of talk about what are the needs, what are the requirements, but most importantly, how AI and data science is either helping or has the potential to help in each of these phases. So let's get into it and start with preparedness. Preparedness is, of course, this is even before something happens, and there is no alternative for preparedness. Every nation, every country, we as a people need to be prepared for crisis, for pandemics like this. And I'll start with a 1-minute video from 2005 as well as 2012, 2015 about the presidents of the United States, past presidents of the United States, talking about potential pandemics.
It is vital that our nation discuss and address the threat of pandemic flu now. There is no pandemic flu in our country or in the world at this time. But if we wait for a pandemic to appear, it will be too late to prepare. Pandemic is a lot like a forest fire. If caught early, it might be extinguished with limited damage. If allowed to smolder undetected, it can grow to an inferno that spreads quickly beyond our ability to control it. Our strategy is designed to meet 3 critical goals. First, we must detect outbreaks that occur anywhere in the world. Second, we must protect the American people by stockpiling vaccines and antiviral drugs and improve our ability to rapidly produce new vaccines against a pandemic strain. And third, we must be ready to respond at federal, state, and local levels in the event that a pandemic reaches our shores.
We have to put in place an infrastructure, not just here at home, but globally. Allows us to see it quickly, isolate it quickly, respond to it quickly. So that if and when a new strain of flu, like the Spanish flu, crops up, 5 years from now or a decade from now, we've made the investment. And we're further along to be able to catch it.
Little did President Obama know that when he said 5 years from now, he was right on the money. It actually did happen 5 years from when he made the speech. So, we'll slowly parse all of this. We heard a lot of terms of stockpiling and many of these things. So we'll slowly start unraveling all of this during the course of the presentation. As you notice, one of the things was, how do we catch this even before it starts reaching our shore? So AI is, it can be used in early identification of these pandemics. There's a company in Toronto called Blue Dot that actually predicted not only that this is going to get into a pandemic even before this was a pandemic, it also mapped out the transmission of which countries will be affected next and how they will be affected. Unfortunately, no one paid attention to them at that time. After this became a pandemic, people started paying attention to this company, and the Canadian government now uses them to model the transmission and model the growth of this pandemic within Canada. And it uses population characteristics, it uses travel data from flights, travel mobility patterns within the country, and so on and so forth. And so there are artificial intelligence techniques that actually can identify early enough these things. And interestingly, there was a in very early days during my PhD, wrote a paper on automated syndromic surveillance from New York pre-hospital care reports. And at the time, the driver wasn't really a pandemic; it was post 9/11 era. And people were worried about bioterrorism, and we had access. I was in New York. I was doing my PhD in New York, and we had access to what we call this New York State's pre-hospital care report forms. Every time someone calls 911 and the first responders respond to it, they fill out this PCR form. And the idea was using these PCR forms perform automated syndromic surveillance, by finding unusual patterns or symptoms that could potentially point to a bioterrorist attack, and it can be used the same thing for pandemics. And interestingly, just over the last few weeks, on ResearchGate, I saw that this paper was being read 3,000 times. People going back to the old type of research on how these can be used to perform early identification. Once we talked about early identification. There was also another term that was thrown in the presentation, which was called stockpiling. This is a common term, where we think of it as a backup inventory of essentials. Hospitals and healthcare centers, they have their own supply chain, but there has to be a stockpile, a backup at a federal level, at a government level, of these essentials. Under the Preparedness for Pandemics Act in the United States, the government was mandated to create a strategic national stockpile. And what basically meant is that they would store vaccines, drugs, personal protective equipment, ventilators, and imagine all of these things that we need in this current pandemic, with an aim to be able to deploy these resources at a 12-hour notice. So where does artificial intelligence come into this stockpiling? Now there are major considerations to what, of stockpiling. What do we stockpile? How much do we stockpile? How do we send help, and where do we send help? And these are areas where artificial intelligence has or will help. So for example, the stockpiling strategy, meaning what to stockpile and how much to stockpile. This is all data driven. This is all being used. There are artificial intelligence, machine learning algorithms being used in all of this. So how do we demand what our inventory? How do we create what our inventory would be based on prediction of the demand? And again, the parameters that would go in would be the medical vulnerability of the population, how the threats occurred in the past, what was the need in the past, how would we how we respond to them in the future, which medicines are easily available, readily available, what medical supplies will we need, will we not short of, and so on and so forth. And again, some of the factors would be, of course, storing everything has a cost, there's efficiency needed for it. So all of those go into machine learning models. So think of an inventory management system. It really ties well into a type of machine learning we call reinforcement learning. In reinforcement learning, think of this as an agent or a robot not a real robot, could be a software agent that's working within a system, has a particular state, and performs a certain action. And based on that action, it gets a reward and goes into some other state. And these inventory management systems, tie very well into this kind of a machine learning model, where you have penalty if something, you give penalties to these algorithms if something goes out of stock. If there's something stays on the shelf for too long, that again is a penalty. There's a reward every time you're able to meet a demand by having something in stock. And then there are actions that you perform and you get on that, and there's an action state. And using these inventory management, machine learning systems, it was noticed, in the past that there's at least a 30% increase in the efficiency, reduction of cost, meeting demand, and so on and so forth. So once you have these stockpiles, the next important thing is, how do we respond when there is a need for these things? How do we respond and quickly make sure that they are enabled? And that's where AI again comes in. It's been heavily used in the current pandemic on rapid response logistics. UK Department of Transportation and approved use of AI-enabled drones, deliver medical supplies, kits, and medications and whatnot. In fact, in China, they used these drones to deliver swab samples. They had many of these testing stations, and they used drones to transport these swab samples from these swab stations to the Chinese Center for Disease Control. And another thing in the past that happened was a kidney was transported by a drone to the University of Maryland Medical Center in the United States. So basically not just the response for the actual pandemic, but remember there are needs within the pandemic that can be impacted by the pandemic, the regular needs that are happening in daily life, something like a kidney transplant, and there was AI being used in there.
So Faisal, any idea what kind of AI was being used in the drones? Was it they were like flying out of range, or any?
So some of the things that were being used is basically which locations, for example, send it to.
Right,
so let's think of the Department of Transportation. They enable multiple drones. And they were at multiple places. So how do you schedule which drones to use? Which is the nearest drone? Then the other thing, of course, using vision technology to be able to navigate and use, and then of course GPS technology can be used. In the Chinese case, where they deliver swab samples, the optimization needed to be done was how to reduce the time of sending these swab samples to the Center for Disease Control. And basically the idea was sending those drones and keeping them at strategic locations. So which location the drone should be sent out of to the nearest location, to the nearest swab station, and then getting it back. So more of scheduling issues on which drones to send where in these situations. So another important thing that has come about is in terms of preparedness. And again, people often underestimate this, but this is critical. And now it has shown during our current pandemic the need for building these national health data platforms, because it's critical to access the information that is generated, especially clinical information or epidemiological information. And to be honest, participation in these near real-time population health registries should be mandatory for all hospitals, for all care providers. And it's always been on the back burner. It's always been on strategic charts and PowerPoints. Every time a consultant is paid big dollars, they will come and give you these big presentations of need for these health data platforms, but often has lacked execution. But if the current pandemic has shown us anything, that in order to drive these AI algorithms or data-driven decisions, where the right data can save lives at the right time, we need these national health data platforms. In fact, NHS just partnered with a tech giant to develop a COVID-19 data platform. In fact, they plan to grow it into a bigger national data platform, but at least start off with a COVID-19 platform. So again, so this was sort of talking about the preparedness aspects of what we could do or what we could have done, before the pandemic started. Let's go into the response phase, which we are really living right now, because we are currently in the response phase of the pandemic. So the health system is a quartet. Anybody that knows what a quartet is, it's four people singing group or four people music group, right? But the health system is really a quartet. It works on four pillars, right? The primary care, where it's more on wellness and the first contact with physicians. And there's secondary care, where referrals happen, specialty care like cardiology or orthopedics and whatnot. Then there's acute care, for hospitalizations, that's our tertiary care facilities, and then long-term facilities like, nursing homes and skilled nursing facilities and whatnot. And the assumption is that at any given point of time, only a small fraction of the population uses this entire quartet. Now, in a pandemic, what could happen is the percentage of population rises significantly, it becomes too big, or it rises too quickly for us to be able to respond, which can lead to a health system collapse, leading to high mortality. And that's why we keep talking about, as Sanjay mentioned, we keep talking about these non-pharmaceutical interventions like social distancing and shutdowns. And the idea really is to keep us within that capacity. So how do we know how to manage all of these things? And I'll talk about how we usually model the epidemic. But again, I'll very briefly touch over this, but on May 7th, Sanjay and some of his colleagues will lead a session actually that will go into detail on how we model these epidemics. So, in epidemiology, people use these compartmental models where people are assigned to compartments and they can move between compartments. A popular model is called the SEIR model, where people are susceptible. Think of this, a fraction of population, which is 100% of the population is susceptible. That's the blue curve. And slowly people start getting exposed and infected and either recover or die. So this is the compartment, the susceptible compartment, the exposed compartment, the infection compartment, and the recovered compartment, or people that are removed from the system because they die. Because we're interested in the health services and management of health services, we're really interested in this part of the curve, this piece of the puzzle, which is your infected curve. So let's zoom into the infected curve and think of if that orange line here is our health system's capacity, and it's usually flat, but I'll talk about it later. If this is our capacity, and that curve is which we zoomed into, as you can see here, this is what represents a health system collapse. Right now, the need for the health system is significantly larger than what our health system can actually cater to. And this is what a health system collapses. So in order to prevent this, we have been hearing these terms like social distancing, and where social distancing is sort of more on an individual level, and then we have shutdowns that are government enforced and regulated. And the idea really is that we reduce the number of people that are exposed and susceptible at any given point of time, thereby reducing the infected curve. Now, social distancing or these shutdowns, it's not a one size fit all, right? It's just not shut down everything and that's it. So we'll talk about something called a social distancing factor, which basically means that if we do social distancing at an individual level, think of we're reducing our social contact by 10%. Similarly, if parks and other things, recreation are closed, another 10%. Schools are closed, maybe 20%, and so on and so forth. So and I ran a simulation on how this would pan out. So this is the scenario where we had no social distancing. Let's say we now close down all the recreation parks, and it will bring down the curve, and we are now started flattening the curve. Let's say we add another thing and we start shut down schools. that brings it down further. And then so on and so forth, till we reach a point where, as you can see this purple curve, now we are under our health capacity. Which basically means that at any given point of time, even at the time of our maximum need, our health system can still manage the number of people that are requesting services. Now, all of this has only one side of the story. What we're missing here is that all of these shutdowns also lead to economic impact. This is a slide HSBC prepared. This was basically the percentage contribution towards the GDP in the United States by each sector. And it also shows that a week of shutdown within each sector, how much of an impact on the economy it has. Long story short, 1 week of shutdown can actually impact economy by 0.5%, 0.8%, which is huge. And Sanjay was recently telling me that the economy shrunk by 1 point something% here, or in the GCC area. In the US, actually, in the last quarter, the economy shrunk by 4.5% in the first quarter of 2020. So this has very significant impacts, and this impacts our future as a people. So now, so basically what happens then is that it's not just the social impact factor that we need to look at. We also need to look at what is that economic impact that's going to happen by doing this. So as we go down the curves and we flatten it more and more, which also means that we are making our economic situation worse. So then how do we do these data-driven lockdowns is, if this is the curve where, as we are following the peak of the social, peaks of social distancing, is there a way we can operate somewhere where the economic impact is still manageable? Of course, there will be some, but it's not as disastrous as the last one. But at the same time, as you can see, that means that we will be above our capacity. How do we manage that capacity? So the idea really is that without mitigation, this is what happens, but in reality, we will also increase the healthcare capacity somehow. So we act on both situations, and that way, what we can do is we can do a phased shutdown and not a complete shutdown at the same time, making sure that we also sort of shore up our economy. How do we now increase healthcare capacity? Of course, one simple way of doing it is, on the left side, you'll see a picture, and where I come from in New York, this is one of the largest convention centers there. It's called the Jacob Javits Center. And there's a lot of AI and machine learning conferences, actually, by the way, that I have attended in this center. And this particular event is probably the Comic-Con festival. And you convert the center like that into this, into a makeshift hospital. And that's what the Jacob Javits Center right now is in New York, because New York was really the hub of the pandemic within the United States. Now, this can increase our capacity, definitely, but this is something which is not feasible for every country. This is something that is economically draining. This requires marshaling of resources and logistics at a phenomenal scale. So what we do in other situations is to make sure then, how do we organically increase the capacity within the health system by trying to schedule it in a way, by trying to process it in a way that at any given point of time, the number of people that actually need that particular segment of the healthcare, be it primary care or secondary care or tertiary care, is less than the actual need, the actual capacity, by sort of distributing it over the spectrum. To be able to do that, what we need to understand is which pieces of the puzzle are being impacted the most. So in the current pandemic, for example, in COVID-19, the key areas that are being impacted are emergency rooms, where it's outcrowding the emergency rooms. It's putting a strain on outpatient clinics by, people having symptoms and they want to know, do I have COVID? They want to rush into these hospitals, these primary care or, outpatient clinics. Then once someone is hospitalized and they may need ventilators, they need to go on ventilators and within ICUs, then our ICU capacity is being strained. And then there's also the collateral damage. I just recently read this piece of news where, a hospital, in order to make space for COVID-19 patients, was discharging or forcefully discharging their patients. And one such patient, there was news of one such patient that was discharged and died in 2 days, right? So that's your indirect impact of on the health system that this has. So how do we now spread the resource need or allocation in such a way that at any given point of time, none of these is overwhelmed? For that, WHO came up with guidelines. And again, these are not actionable steps, but these are just guidelines that WHO came up with. They came up with a general preparedness and response plan for the current pandemic. It had 8 pillars of operation, and they covered all aspects. The pillar that specifically talked about the health capacity was this pillar 7, was case management. And the actions that it has to be taken was to make sure that we map vulnerable populations, we increase capacity by spreading things between private, public, and alternative facilities, making sure we identify our intensive care capacity, access continuously the burden, and then there is sufficient guidance on self-care for the patients. So what does this now translate into how data-driven tools and AI is helping in each of them? So this is a report from Imperial College London, where it was sort of the initial reports on the mapping case severity by age. And again, this is not the only way we map the case severity, because we have to take into consideration pre-existing populations and vulnerable populations and so on and so forth. But in this case, I'm only looking at, for example, stratification by age. And as you can see, the hospitalization rates for younger people are much lower than the hospitalization rates for older people. And then the fatality ratio is also much lower. So how can we use this? If we, for example, try to project what our demand is going to be simply based on this, again, this is only the age, and we have to look at other things. But in this particular simulation that I mapped onto the previous simulations, is I'm only looking at age. And what this basically means is, now, if I go back to those 3 scenarios of social distancing that we used in the simulation, and map this age severity caseload on it, we'll see that if we do nothing, of course, we're above capacity for a particular health system. But if we map the age on age, based on our population mix, the age on it, we'll see that even with the simplest of scenarios, if the reproduction rate is, let's say, 2, even though the literature has talked about anything between 2 and 2.6, so I just ran a simulation for all of them, we are under capacity for most of the time. And for a particular reproduction number, we can increase our social distancing and still be within capacity. Now, how do we do that? We basically make sure that the people that are not at as high as a risk can stay out of the hospitals, can stay out of the emergency rooms, can be taken care of either in the outpatient or in their homes by proper triaging, proper and proper management. Some of the tools being used, the AI or data science tools being used are self-assessment tools. There's many of these tools that were created during this time. In fact, this is one created by United States Center for Disease Controls with Apple, and it's an app that everyone can download and try to get a self-assessment, so to reduce people going to physicians. In fact, we at QCRI also created a self-assessment tool for the region in 11 languages, and these tools have been used millions of times. Even our own QCRI tool has been used by over 1 million people. And what this basically does is people can now, whoever has questions and is worried can take these self-assessment tools and is informed about what next steps should they take.
So, Faisal, a quick question here. The question was, is Qatar, if you go back to the previous slide, is Qatar actually using some of these ideas here, like the risk stratification, caseload?
Yes, absolutely. So there are there is strategic planning being done within Qatar because of how our age mix is within the country. As a country, we are a very young country. A majority of our population is young, and thank God that's one of the big reasons why the severity within Qatar, even though we had about 14,000 so cases right now, our mortality is very low. Only 12 people have died so far, and our ICUs are also not overwhelmed. So yes, people are actually using a lot of this risk stratification to understand what capacity should I need. There isn't a lot of emphasis right now. Again, that's probably because of lack of data, within the country, and not just Qatar. It's global. It's a problem globally on how do we do phased shutdowns, which shutdown should we do, what is the economic impact. So to be on the safer side is basically sort of taking an all-or-none approach and only keeping essential services open. So those things are being done, but at a hospital and utilization level, definitely these things are being considered for managing capacity. For when should I create another hospital? For example, the hospital in Al Khor is now a completely COVID-19 hospital. All non-COVID patients have been transferred to some other places. So that's part of how we increase capacity based on these ratios of and risk stratification.
Thank you.
So, there's other tools that have been created. This is an AI-based tool created by Google. It's called COVID Near You, and it's a tool to understand hotspots. Basically, people can use this app and enter their symptoms on a daily basis, and based on their inputs, as you can see, this app says that your contribution will inform public health with real-time insights. So this basically shows if there are hotspots coming up within particular zip codes, and zip code is a local area within the United States. And people use this app and enter their symptoms. And if a lot of people are entering these symptoms, that means this place is potentially becoming a hotspot, and there will be a strain on public health, so that they can forecast caseload. Now, again, as on a side note, Google did create something called the Google Flu Tracker before this, and that failed miserably after some time, because at that time they were using people searching about flu, not entering their systems. People searching about flu, and that really changes seasonally. So using that as a surrogate. So again, using these data-driven things do come with pitfalls, but again, they have to be used correctly. This is one of the AI tools that being used. Now in triage, this is the extremely important thing that AI is being used, and in many places it's not used, and there's a lot of potential. So, for example, we don't use any of this in Qatar or any places. Even in the United States, it's not used all over the places. In only really high-end hospitals, this is currently being used. So, and what this basically does is, the AI tools using past data and the current data of the patient generate a disposition whether you should be sending them home, how much of a risk they are at. So you should be sending them home. Should they be hospitalized, ICU, put on ECMO and whatnot. And then you can continuously monitor them if there are changes. In fact, in certain countries, they're proactively using the tools, even without people showing any symptoms, even without people coming to the hospitals, from their patient registries, creating at-risk pools and prioritizing them for testing, prioritizing them for monitoring. These are AI tools that are already being used for that. Now, once a decision has been made that this particular patient, could be a young person who has COVID-19, but is not considered at high risk. How do we make sure that they are monitored at home, so that the situation gets worse, and sort of not just relying on them either coming back or making a phone call? So this is something that's being used in Oxford, United Kingdom. This is what the patient, on the left side, you'll see this is what the patient is given. This is a pulse oximeter, and there are other things, heart rate and other things that these devices monitor. And the app is downloaded either on their iPad or on their phone. And then this is the doctor's view of these, where these are for example, 4 patients that they are monitoring. And these are all 4 patients that are, that are in their homes, being monitored by these physicians using these devices. And these systems will then generate alerts if, for example, someone's oxygen saturation starts decreasing, which is a common thing that happens in patients that end up in ICU for the current COVID-19. They can be called back and say, and to go with that, there is, the concept of telemedicine. Again, this is a, company, Teladoc, United States, just sort of an Uber of physicians, an AI-based app. This has seen 40% increase over the last few weeks because of COVID-19. What this basically does is it not only provides care for people that are experiencing symptoms or want to ask about COVID-19, but also provides continuity of care for people in general, that are either, may have a common flu or just broke their leg or something like that. And what this basically means that this 40% increase simply translates into a decrease of people either going into clinics or into emergency rooms and hospitals. So you basically maintain, manage that capacity outside of the quartet. Once the patient has been, for example, hospitalized, there's this strata of patients that will be hospitalized. Now, there are tools being used for better risk assessment and planning. There's this language tool by Epidemic Monitor system that is being used to estimate how long this patient is going to stay in the ICU, for example. It says, for example, currently the patient has been for 4 days and the estimated length is 13 days. This is extremely important to manage the caseload within the ICU and to be able to forecast how much I can use, when will my beds be ready for more people to come in. And there are these scores that are being created. These are scores that were already over there, but are being now modified for the particular case of COVID, for a simplified acute physiology score, on the severity of this in the ICU, as well as something called SOFA, which is the organ failure assessment, which is a common thing that happens with people on ventilators and ECMOs. Now, what this does is basically this helps in utilization forecasting, and this is something that people have been doing now to predict the number of ventilators. There's a lot of countries that are using AI and data-driven, data science to predict how many ventilators would I be needing. And they go down the spectrum and say, what is my daily growth in cases? What percentage of that am I looking at, basically, which will be hospitalized based on the past data? What percentage of hospitalization will require critical care, and how many of them will require ventilator support? And at the same time, mapping it to the capacity. How many ventilators are currently not in use? How many will become available, for example, by using that length of stay indicator, and and that may be available for future use, right? An example of that is a perfect example of that is patient attribution in Sweden. And this is phenomenal. What Sweden is doing, this is a chart that and as you can see, the last date on this is, I took the screenshot yesterday just to convey the message. The last date on this is May 4. This registry, this is a national health ICU registry that is connected throughout the hospitals and is updated every 30 minutes to understand what is my ICU capacity right now, how much is it being used, and how much do I have. So that patients can be allocated within X mile radius instead of going up to a hospital and they're saying, they're raising their hands and saying, we don't have any capacity, go take them to the next hospital and wasting important time. And, you can also transport between facilities because, someone on the floor that needs an ICU bed and there is no ICU bed in the ICU can be transported to another institution by just looking at it and seeing which institutions have capacity. So, AI being used all over there as well.
Sorry, going back to that curve. So once again, what's the origin, the blue? Could you explain that?
Oh yeah, sure. Sorry. So this is in Swedish. So what this basically shows is this this is the previous day's usage and the current day's average usage, and then you can drill down onto the exact current numbers as well. So this one basically shows throughout the year This is the throughout the this is the timeline. This is the average usage across all institutions. And this is the one in blue is the one that's from the previous day, and the one is the current day.
Thank you.
So now, as I mentioned, there's collateral damage. There's indirect impact as well. So there are algorithms being used instead of simply making decisions on shut down all non-essential services without having a good definition of non-essential. How do we create models that are more ethical, that not only say, okay, my definition of critical versus non-critical, but also take into allocate, these are called allocation frameworks, take into account how many lives would I be saving, simply, whether I will be saving lives or not, to what will be the quality of life if I shut down the service during this pandemic. Similarly, simply not only saying how many life years will I save, but will there be an impact on lifelong productivity for a particular patient if I shut down this normal service? For example, someone with a heart disease, and the clinics are shut down. So and University of Pittsburgh actually came out with one of these frameworks where where they're now, which is also very interesting, on how do you introduce ethics, and how do you introduce compassion into these machine learning models, make sure that they're not biased, because a lot of the data that they're getting would, for example, say, for a particular segment of the population, would say, this is not essential because the impact on that population is not as much, whereas for the same thing, an impact on some other population would be high. So these are frameworks, future areas of research that they're pointing at. So we talked about the response phase, of how the way AI is helping in our current response to keep the utilization at a stage where our current capacity or improving, or the slightly increased capacity can cater to it. Where do we go from here? As we are now looking into opening back our economies, starting, quote unquote, whatever the normal is. How do we open up, and when do we open up, and how is AI and data science going to help there? Again, going back to the simulation that we did in the beginning, I used the same parameters over here. How long should we keep this shutdown, right? Again, this is using the same parameters. This simulation, what this basically shows is that longer the shutdown, of course, it's going to have an impact on the susceptible fraction. Again, remember, it's the susceptible fraction reduced, which basically translates into a reduction in the impacted. So as you can see, as we keep the lockdown longer, it helps, but at some point it just flattens out, which means keeping it longer than that is not going to help at all. It just basically plateaus at that point. Now the question becomes, okay, then how do we decide how we reopen? Do we reopen as soon as the peak starts coming down? And again, what the simulation, again, using the simulation, if we end the shutdown early, which basically means we reach the peak, and as we were going down, we start to reopen. This, I ran the simulation using two social distancing factors. And remember, we were at 0.6 when we were under capacity. And if we reopen too soon, the next peak is going to come back with a vengeance. It's going to be higher than the previous one. So, and if we keep it longer, then the next peak is going to be smaller, even with a very low social distance, which is 0.1, which is basically simply maybe not opening cinema theaters or something like that. I don't know, whatever that is. But so if we keep it longer, then it happens. Again, going back to which basically means that we need to optimize these lockdowns so that we prevent these resurgences. Going back to that table where we showed about how we could have these, we can open up the economy and have these triggers. On the right side is a chart that's in the Imperial College London report, which basically uses something similar and says, if I pick an on trigger On trigger means if my number of cases or number of ICU cases reaches, let's say, 60 or 100 a week, I need to, again, institute lockdown measures, right? And which scenario of lockdown do I pick? Not just simply, oh yeah, just lockdown. Like, which scenario of lockdown? Which pieces do I lock down so that I don't impact the entire economy? And they made these simulations over here, which basically shows that over a period of time, intermittent lockdowns with very low social distancing after the first peak is going to be sufficient to keep us under capacity. And this is where, data science and machine learning will help us to understand how do we open up and how do we then have intermittent lockdowns to make sure that we don't have big resurgence. What other thing in the recovery phase is going to be extremely important is to understand clinical pathways and outcomes. In the recovery phase is when now we will have some sort of a time, even though this could have happened during response phase, if there was an infrastructure, a data infrastructure in place. Now that there isn't, we can do this in the recovery phase as an understanding which group of patients ends up without a problem, right? Completely asymptomatic, or maybe very mild symptoms. Which group ends up needing care, needing hospitalization even, and they recover, and which group actually ends up in ICU and ventilators. And we know that once a person is on a ventilator, their chances of survival are not that great, right? So what are those underlying factors? Again, factors, not just clinical factors, socioeconomic factors, behavioral factors, as well as clinical factors. What are those factors that describe which pathway the patient will follow? Now, this is going to be extremely important to understand which patients should be treated how and managed how. Again, when there's no treatment right now, how should they be managed? Another thing that we'll basically do is comparative effectiveness. Remember, during the response phase, we were playing whack-a-mole. Something popping up, we trying to manage that. Many of these trials that were happening, they were heterogeneous. There was no standards for these trials. Again, not to blame anybody, what the physicians and the care providers at that time were doing, they had one objective that was to save lives. So people were being given multiple regimens, knowing that maybe none of them works. There were no control in these trials. There were confounders in these trials, multiple confounders. So what we can do going forward is to understand the comparative effectiveness, by, for example, doing a meta-analysis on all of these. At the same time, figuring out if some parts of the trials which were maybe confounded or maybe not controlled well, how can we generate these auxiliary trials, which just add-on trials instead of repeating the whole trial. And again, AI and especially reinforcement learning used in trials can have an impact over there. Again, I'm not going. And again, on May 11th there will be a lecture on drug discovery and how regimens and how treatments can be discovered. We'll go a lot into detail at that time. Which brings us to the last phase of the crisis management, and that is mitigation. Now, once we go into our quote unquote normal, and the reason I'm saying quote unquote normal is who knows what that new normal is going to be. We know this disease hasn't gone away. We know this disease spreads fast as it used to. We know a little bit more about the disease now than what we did when it started. But how do we control it and make sure that our health system is managed well? There are lots of things people are trying out, people are suggesting, and things that people are piloting. As an example, these surveillance techniques in Australia, pandemic drones have been actually approved to on the right side to do surveillance on. For example, these are thermal scans that give you an idea of the temperature, if that person has a fever, are they coughing, to try to sort of isolate them and maybe point out if they have COVID. there are lots of research, again, it's very, very early stages. We don't even know if it will work, on trying to understand, is there a particular tone to the cough, or is there a particular frequency to the cough that can differentiate a regular cough from someone that has COVID, so that we can sort of put microphones in offices and other places and do surveillance. And then there is this, from landing AI, there's this tool which actually uses CCTV cameras to understand how much social distancing people are adhering to it. And again, these create lots of issues and lots of concerns on people's privacy, lots of concerns on civil rights. But many of these things are being considered. Many of these AI techniques and technologies are being considered for use in the mitigation stage as we start to live with this virus, if you will. Other things that are being used, for example, are in tools in contact tracing. There are mobile apps, various flavors of these mobile apps. Some use Bluetooth, some use a combination of Bluetooth and GPS, some use only GPS, some use only call records and whatnot. And how it works is basically, if two people meet for more than a few minutes, and they exchange a token, as long as they have this app and the Bluetooth is on, they exchange a token. And none of this information is made public to anybody till one of those people is now identified as COVID positive. And as soon as that patient is identified as COVID positive, all the people that came in contact with this patient are sent messages on this app that you were in touch with a particular patient that was COVID positive. Again, for lots of privacy concerns, many of these, lots of frameworks people are suggesting on how to use this in a privacy-preserving manner. NHS actually rejected the Apple Google plan app because it just did not pass their GDPR and EU muster. So lots of issues with these apps. But again, in the mitigation stage, lots of avenues where AI can help. Again, in drug discovery, in treatment selection, in therapeutics. Again, which will be talked about in one of the future lectures. So now coming back to my favorite topic, this is something that has been ignored for a long time now. There's a lot of startups that work on digital health. There's a lot of buzz around digital health, but there wasn't a concerted effort on actually making this work because of a seamless ecosystem, or having a ecosystem, or having a seamless workflow on within payer systems and provider systems, as well as within the public health. It was always on the radar. It was always on something which looked pretty fancy on research slides or these consultant slides that charge you a lot of money. And I pointed this quote out from Asaf Barnea, who's the CEO of one of the companies that is funded by Philips and Teva, two very large organizations. And he made this comment: "The necessity is the mother of digital health," which basically says that we all ignored it enough, and COVID-19 has now shown us that there is a real necessity for this, because this is what's going to help us in managing many of these things in the future. And remember, things like diabetes have been called pandemics for a long time now. They're not real pandemics, but given how prevalent they are, it's almost called a quote unquote pandemic, and even in those diseases. So I'm not only saying this because this is my area of research, but this is something that's going to play a bigger role, and governments really need to invest in a strong digital health ecosystem. And thankfully in Qatar, this is one of the strategic pillars that the health system is working on. We're in very early stages, but this is identified as one of the key drivers. So in conclusion, AI and data science, as hopefully I was able to demonstrate, are being used in the current response phase for managing the health services in the pandemic. It can play a key role as we go into recovery and mitigation phases. Having said that, honestly, preparedness has no alternative. It's like insurance. Everybody hates paying for it till you need it. So we need to invest in being prepared. And part of preparing that, coming from an AI and data science perspective, is to build these health exchange, data exchange platforms, is to build these health data platforms, is to invest in digital health, which is going to be a key factor in our new normal. Thank you, and we'll be happy to take questions.
So thank you very much, Faisal. Couple of questions that came up were like for the Swedish case. So is their ICU capacity overwhelmed or not?
Not according to the charts. There were pretty few regions, and overall capacity was not overwhelmed. There were a few regions where there was a much broader older population than the mix of the population was skewed towards the older population. They were having strains, but strain on the ICUs. But remember, what they did was they made sure that they do patient attribution to these institutions, that they don't rush to the nearest institution necessarily. They rush them to the institution that has the capacity, that has the forecasted capacity. Remember, COVID-19 is not, in majority of the cases I'm talking about, is not one of those things like someone has a heart attack and they need, a ventilator or something right away, right? There's a time where you can actually plan. So if a hospital has a forecasted capacity, then you would take that patient there, hospitalize them on the floor till they actually need that. So tools like this are extremely critical over there. So as far as my knowledge goes, that they did not, even though their death rates are slightly higher than the rest of the region, but that's mostly because they never instituted any lockdowns. It was only social distancing at an individual level.
I think Sweden was a very interesting case. They had no
exactly
lockdowns, and yet they were able to. Another question was, this was more related to the app you mentioned, the COVID app. There's a similar app from MOI called Attribution. Do you know anything about it, or what's the update on that? Or
yes, so there is an app called Attribution, which is sort of serves dual purpose. It's an informational app as well as planned to be a contact tracing app. It does need access to your Bluetooth and GPS if you download it. Currently, how it's going to be used, is not very clear, at least from the public information. But it is definitely a contact tracing app as well as an information app, because what it does is, if someone is known to be COVID positive, their barcode color actually is red, and that barcode is not only just a color, a flag. It also is their information, so they can actually take that to a health center, and that can be scanned, and their history can be brought up. So yes, that is in fact one of the apps that I mentioned is based on similar platforms.
Thank you. Another question was, do you know if AI is being used to understand all countries' policy response to lockdown measures and reopening economies? WHO have expressed concerns that if countries like UK and US reopen too soon, it'll have a big impact on developing countries.
Yeah, absolutely. And it's one of the things that I mentioned. Many of these models that are being created on resurgence and other things do consider mobility patterns, do consider your flights and travel patterns, and to understand that. So many of these data scientists and public health experts are using data science and AI to map that out, and that's why they're kind of saying, and it's not purely anecdotal, that they're saying that opening up too early may have a rebound effect, not just within the country, but because of the global mobility. We're never in the history of mankind have people traveled so much between places. as we do nowadays. That is also being taken into account.
So another related question to resurgence was, what's the logic behind the, second resurgence being even higher than the early opening? I mean, the second peak is sometimes higher than the first.
Right. So remember, so that's a good point. So one of the things that happens is, when I was, for example, running this simulation, in the first bump, the input basically is that when the people that are exposed start going up from a point which is very low, which is 0 or very low, right? In the second bump, what happened was, what I simply did in the simulation was the output of the first simulation went as the input of the second simulation, which basically means that there were a lot of people at that time that were exposed and infected, right? So once you release the social distancing measures, imagine there's a lot of these people that will go out that many of them don't even know that they're infected and can actually, can actually infect a lot of other people. Having a longer tail, which basically means that many of those infected people will now actually not shed virus. Many of these will actually, cure themselves, or just be cured automatically, and will infect lesser people than they would if immediately I were to. Remember, it's the fraction of the population that's still infected that goes into the second portion of the model, and that's a lot higher than if you look at the first version.
There's actually a Qatar-specific question too. It says Qatar has the highest per 1,000 confirmed cases by a significant margin in the GCC. Why do you think Qatar has not yet resorted to lockdown measures, even for a week? I guess it probably has, but I guess it may be extreme lockdown measures since
I mean, one of the reasons for our high numbers is the mix of the population. We have a very large worker population in industrial areas. If you look at the hotspots, that's one of the hotspots, and the living conditions there. There are many people, many of these laborers living in one room. One person gets infected, it's basically everyone else getting infected. So that's one of the reasons there's a large number of people. And it's a good question, why we haven't gone into a specific lockdown is, again, going back to these data-driven methodologies. As far as till now, the data has shown us that our severity is on the lower side, and even when we are on one of the highest cases per 100,000 or per million, our ICU usage is not high at all. Our hospitalization rates is not high at all. Again, that doesn't mean that's not going to change, because a lot of the cases right now were coming from industrial area, which is young laborers, very strong, sturdy people. As it gets into the broader society, where there are, uncles and aunts and parents and grandparents and, ups and judds and all of that. So it's going to be a completely different story. But, many of these things go into that decision making again. So it's, I think in their infinite wisdom, the policymakers are looking at that. That would be my guess.
I think maybe you can conclude with this final sort of higher level question about AI. So what is it in general? What is your perception that, if you had a report card of how AI and ML are doing in this, to respond to the pandemic, what would you think?
To be honest, it's a dichotomy. There's two things to it. One, there's a lot of hype that is created, which, to be honest, a lot of it is created by researchers like us, but it's counterproductive. It actually comes back to hurt us. And by saying, "Oh, I'll do this COVID," and again, there was a very scathing review on one of the papers that was published on identifying COVID by X-rays and using that as an alternate test strategy, which basically shows that they don't really understand how the health systems are working. Because by the time you can tell someone has COVID from their X-ray, you don't honestly need to say that. But they are so sick that they'll already be something. On the other hand, AI and data science has really shown its value and people are now believing more firmly in it than the people that were initially hesitant. And as you can see in many of these technologies that are being used. So it's at both ends. The one thing that I would like to mention is that we could have done much better, had we been prepared, and we have access to the data in the right time. We could have done a much better job using our AI technologies if we were prepared, if there was enough investment and enough emphasis on creation of these data platforms and creation of these data sharing strategies. A lot of the AI things that are very promising and have not been able to show impact is because we weren't able to get data and because of the lack of data.
Okay, thank you, Faisal, for this very interesting talk. And thank you, everybody, for attending. And hopefully you will get a chance to come to our lecture again on Thursday. Again, see you then. Thank you very much. Bye-bye.